Good afternoon, everyone. Thank you for joining the first PNQIN Equity Bundle webinar of 2024. As everyone's getting logged on and settled, we're just going to go through a couple of our usual housekeeping items. Please type your name and institution into the chat for attendance. And optional share. Oh, can you go back, Caroline? Optional share in the chat. We'd love to know what you are looking forward to in 2024. As always, too, please mute yourselves when you're not speaking. Feel free to type any questions you may have into the chat during the webinar. And this session is being recorded and we will upload it to our website afterwards. Thanks everyone for getting the chat going. And I see Dr. Meadows is here. Hi, Audra.
Good morning, everyone. Sorry that I'm not on camera. I don't know why I can't get it's a black screen, so I'll figure it out. But good to see everyone. Happy New Year. Welcome back. So glad to have everybody for our PNQIN, what I consider sort of 2.0 a bit, right? That we've spent a year discussing the equity bundle and a year discussing what structures do we think need to be in place in order to really reach our goals around addressing health equity. And probably namely among them is that related to equity committees and that related to being able to stratify our data. As we stated in the very first equity meeting, we don't expect that in 12 months that everyone will be able to do everything cited in that bundle. The goal is that this is where we use our QI talents and skills, and we design goals and we build teams and we work toward creating that infrastructure and then getting to a point where we're able to do the things that meet and match the goals of our institutions and what we want to do for our patient populations. And so what we'll be doing, and as we did also in October, but we'll doing between January and July, is having teams come and present and use this time to talk to each other, see what we're accomplishing, what we're not accomplishing, and actually get advice from each other, and really use this time to build on what our local experiences are and how we can use that information to really raise the bar across the state of Massachusetts. And so I'm really excited to have these conversations continuing into our third Tuesdays of the month through the month of July, and we will host our summit in June. So with that being said, today we're going to listen to the Brigham talk about it, and we're going to go through our usual housekeeping and steps as we get closer to that. But that being said, I just wanted to say to others that are going to be presenting or others who haven't presented but may like to in order to also get some advice, I'm really happy that we can do this as a state to support each other. So as usual, please put your name and your organization in the chat. If you've just joined, as usual, please also put your questions in the chat while the conversation is happening, or feel free to raise your hand and we can let folks ask questions then. And without further ado, let's go to the next slide so we can get started. So we'll have the equity bundle reminders and some announcements to start, and right about 12:20, we'll start the presentation with our very own Brigham and Women's Hospital. So we'll go to the next slide, and I think I'll turn it over to Kaylee. Just also want to continuously thank our group, our equity bundle work group, who, even though you hear us speaking often between me and Kaylee and Kristen and others, really it's the work of a large number of people that have put this together that have allowed us to get to where we are. All right, we'll go to the next slide. And thank you for the 22 hospitals that are participating. We've had as many as 19 submitting data at any given moment. So if anyone needs help or needs a call or a team coaching session with our team to help get started with submitting data, please don't hesitate to reach out. We'd be happy to help. All right, we'll go to the next slide, and I'll turn it to Kaylee.
Thank you, Audra. Just a reminder again, for anyone just joining, please put your name and institution in the chat. And optional, we'd love to hear what you're looking forward to in 2024. I see Nairi from the Betsy Lehman Center is looking forward to attending a class about owls that's being hosted at the Mount Auburn Cemetery next month. I'll throw one out there too. I just got tickets for me and my fiance to go see Lord of the Rings in concert later this summer. So it'll be seeing the movie on the big screen with an orchestra providing the score. So we're really excited. Tina's excited to search for mushrooms in the spring. Sounds awesome. I've never done that. So just keep popping them in. We love to read them. Okay, a few announcements. Next slide, Caroline. We first would love to congratulate the Massachusetts TeamBirth cohort. They just had their final learning session last week. Sorry, all these names can't show up, but I will read them. To Bay State Franklin, Boston Medical Center, Brigham and Women's, Cape Cod, Fairview, Mercy, St. Vincent, Sturdy Memorial, and Tufts. Congratulations on all of the great work that you did in implementing TeamBirth over the last year. We're really excited for you. As you know, our kind of format for the remaining Equity Bundle webinars this year is to have hospital teams come and present the Equity Bundle work that you've been doing. So you'll see Brigham is here to present today, and this is kind of the kind of presentation you can expect moving forward. We have hospitals lined up for every month between now and July. We are still looking for someone to present in April. I know it's a little bit of a dicier time around spring vacation week, but if you are available and have something you'd like to share with the team or want to come on and ask for any advice or guidance from your fellow teams, please don't hesitate to reach out and sign up. Next slide. Looking ahead, for those of you who attended the PNQIN Summit on December 11th, you heard that the next bundle we'll be implementing in Massachusetts is the Perinatal Mental Health Conditions Bundle. As you know, this Equity Bundle in its current version will run through the spring. We'll kind of do a wrap-up session at our spring summit. And then the Mental Health Bundle will formally launch in the fall with an equity lens, of course, and we'll begin hospital onboarding activities starting over the summer. So we're aiming to get everybody ready and set up by the fall so that we can hit the ground running. If you're interested in signing up for that, please feel free to send me an email, but we'll also be giving more information and details for how to get signed up over the next several months. Next slide. Speaking of the PNQIN Summit, we had a great turnout and we had a wonderful time. It was so great to see everybody in person. We had almost 300 attendees, which is wonderful, representing 78 different hospitals and partner organizations. Highlights, based on feedback we heard from you all, the audience, folks were really receptive to the information we shared on the mental health bundle, on the mental health in the NICU program at the Brigham, the equity and systems change presentation from Thea James at Boston Medical Center, and then of course our family voice story from Jessica, her journey through infant loss and using it to create the EMA project was a highlight of the day for sure. We got some news. If you were there, you know that our new DPH commissioner, Dr. Goldstein, gave some of our opening remarks, and we heard later that he was very impressed by PNQIN and by the event that we had put together, and we are on his radar, which was really exciting. Looking ahead to the next summit, some constructive feedback we got from you all was we'd love to see further integration of patients and their lived experience, so you can look forward to that. We're going to be looking for presenters from more disciplines and more community hospitals. And we're also thinking of some more creative ways to engage the audience throughout the day. So we have that to look forward to. Next slide. Here are a couple of photos. Many of you know PNQIN's largely a remote organization because we all work at so many different organizations. So when we get together, it's always a good excuse to take a lot of pictures. So here are a couple of the PNQIN team, of the ballroom during the day, and then of Jessica, our family voice speaker. Next slide. Materials from the Fall Summit are available on our website on a password protected page. So be sure to use this password. I'm putting it in the chat as well. When you click this link, use the password to access all of the slides and then all of the materials that we provided on the tables if you didn't get your copies on the day. Next slide. Can you toggle back and forth, Caroline? I think, okay, there we go. I don't know if I'm getting, it's just me. Okay, there we go. A couple of upcoming events, and then we'll turn it over to the Brigham team. On January 30th, you'll see some familiar faces at the next webinar from the Institute for Perinatal Quality Improvement. Our own Dr. Audra Meadows, Fifi Jop, the former principal investigator of PNQIN, as well as Renee Byfield from the Speak Up program will be presenting on this narrative review of the role of PQCs in promoting birth racial equity. So we're really looking forward to that. And you can register for that webinar here at the link in the chat. Next slide. PQI's 28-day anti-racism challenge is also coming up. It starts the 1st of February and runs through the entire month. If you haven't done this challenge before, it's a great way to just kind of do one small thing every day to promote equity. When you register, you'll receive a daily email with links to each day's challenge, daily opportunities to reflect, learn, and act. We've heard in the past that hospital teams in Massachusetts have talked through each day's prompt in morning huddles, and we think that's an awesome idea. So if you'd like to do it as part of a group, we definitely encourage that, and we hope you will do so. Next slide. Barb says, also excellent reading lists have come from the PQI challenge. Thank you, Barb. Speaking of Speak Up, we do have another Massachusetts Speak Up Champion training coming up on March 15th and 22nd of this year. This is free to Massachusetts perinatal providers. It is virtual. It'll be hosted via Zoom. It's from 8:30 to 12:30 on both days. Excuse me, and you can register at the link I'm going to be putting in the chat. And we do ask that you register by the end of February to make sure that you receive your materials for the training on time. Next slide. And then for those of you who have already taken Speak Up or plan to do so in March, your next opportunity to become a Speak Up ambassador will be in May, on May 17th of this year. Again, this is another free opportunity generously provided by funding from the Massachusetts DPH. So you can learn more and register at the link in the chat. And lastly, the Speak Up program is taking more applications to become a Speak Up faculty member. So the faculty training prepares you to eventually teach your own Speak Up champion courses. So if you really love the Speak Up program and you want to be able to provide the training regularly to folks on your unit or at your hospital, becoming faculty is a great way to do that. You can learn more about how to apply and what the position entails at the link in the chat or through the QR code. And the application deadline for faculty is May 1st. Next slide. Lastly, just want to highlight that the PNQIN website is chock full of resources related to the Maternal Equity Bundle, our past AIM bundles, TeamBirth and PNQIN respectful care commitments. We have literature, we have videos, we have toolkits, anything that we feel could aid in your AIM bundle implementation is on our website. So do make sure you check those out. Next slide. Okay, and with that, I will turn it over to the Brigham team.
Thanks, Callie. I wasn't sure if I unmuted myself or you did it, so I just did that. So sorry for the delay. Hi, everybody. Next slide, please. I just wanted to share with you, and I loved what Audra just said because it is so true that we learn from each other. And it also felt a little bit vulnerable when Kaylee said, okay, Brigham, will you do January? And Karen and I went, oh my goodness. It just feels really vulnerable that we're the Brigham. We should already have this all figured out and everything be perfect. But we're all on this journey, and we have challenges, and every hospital, and it's something that we'll always be working on, but we're happy to share. And I'm happy that you gave us this list. Okay, this is what we want you to describe. So loved Bay State's presentation last time, difficult act to follow, so we'll do our best. So next slide. So many of our staff, nurses, physicians had participated in a lot of the AIM bundles, and we signed on full force to the equity bundle implementation. While many people did attend all the webinars and they were good, a few of us felt like, what happens after that? There was not too many opportunities or coordinated opportunities to discuss what we learned in the bundles and how we can go forward. And it was really hard for us to kind of get started. So it took a little bit, but we did have this program at the Brigham through our quality and safety, was a unit-based team. So the next slide, please. So these unit-based teams, as I said, was from the quality and safety group. And originally they would meet like monthly, and it was specific to units. So surgery had their unit-based team, perinatal had their unit-based team, and we addressed the Joint Commission data, safety concerns. And our group really felt that this was a place for us to really focus and do our equity work, as well as all the other AIM bundles. Now, when we think about equity, many hospitals, Brigham included, all of MGB, realized through the data that equity really had to be the focus to a lot of things that we did. So next slide. And what we found was we really needed to work on a lot of this, and we needed to do it together. But how do we go about it? And we kind of looked to the PNQIN equity bundle, the goals of the organization, and how do you know what you're doing if you don't have your structure measures, process measures, and outcome measures to just see what and how and what we're doing, and is it focused to achieving this goal? So we looked at all these measures to keep up our structure, check. We had a unit-based team, check. We were looking at the data. Always a challenge, and in the beginning, to get the data by race and ethnicity was difficult, but we're there, we're getting there, we're able to find that as well. And then the PREMS data, by signing up for being one of the first cohort for TeamBirth, that was very helpful because that was built in, so that was helpful. I would have to say our community engagement is something that we're still striving. How do we get that patient's voice according to race and ethnicity? And our process measures, staff training. Yep, everybody in MGB had to take an equity health stream. And does that count as bias training? It does include it, but it didn't necessarily have the specifics for the perinatal population that we felt and we believed was needed as well, right? So we really did a push for the Speak Up, and having the Speak Up offered and sent out to staff on a regular basis. And we even had nursing leadership support for that in terms of being willingness to pay staff to attend in the indirect time. So that got a good amount of people forward with that. And then as far as our outcome measures, SMM is such a small number individually, it's hard, but we do try to look at that according to race and ethnicity, and certainly support it into the Betsy Lehman Center. But again, one of our issues being such a large organization, and that's why we hope that our equity team will be able to help bring this stuff back to the team, that it's shared amongst everybody. And then of course we have PREMS. So next slide. One of the, I wanted to just give a shout out to the PNQIN website and the PNQIN team for putting all these resources available to us. So when we first come up with, okay, one of the first things was you have to have an anti-racism statement. So what is it that we need to do? And also we had a challenge because MGB had a big anti-racism statement for the system-wide. And some people on our UBT felt that sufficed. We don't need anything more specific to that. But some of us felt that, yes, we did, and we needed to look at it for our population, particularly what we're seeing with perinatal population across the country and in our state as well, that we really needed to have one specific for us. So we worked on that. And next slide, I'll share with what we came up with. And it probably took, we laugh about this because it took forever to get there. So sometimes it's easier when you're in a smaller organization, you just come up with it with a small group and you say A-OK. But in a large organization with many groups working on equity and many groups feeling they had to have a say, you don't know how many iterations of this that we had and going back and forth, but we finally, this is it. And we did say that, yes, this is what our anti-racism statement is going to be. And we had some goals with that. And our plan is to have it public facing. So we're going to post it like we post the TeamBirth poster in patient facing areas, in waiting rooms, by elevators. One suggestion was also to take this as a little tagline to the bottom of your emails so that it's always front and center. So next slide, we had our goals and now we wanted to work on our SMARTY goals. So we definitely will talk more about TeamBirth, and I think that that was such a great thing for us to operationalize some of the things that we wanted to do. The other thing, we were better able to collect the data. We do it by race and ethnicity, and the Brigham also had a focus on priority neighborhoods. So a lot of things were done by zip code to see how we're doing according to zip codes. But now, of course, with looking at social determinants and ableism, really expanding that equity lens of things. So that's something that we're working on. So the next slide. And again, this was a wonderful thing by participating in the PNQIN and the Equity Bundle, is that we learned that we have our equity dashboard, and many of you have access to the quality, the hemorrhage, the hypertension, how many vaginal births, all that stuff pulled from Epic, but we didn't know how to get it by race and ethnicity. So the learning that we did through and involving Epic, finding that there is an equity dashboard, but we didn't know how to access it. And it was, I guess, part of the basics. So those of you who have Epic in a basic version, it's not a fancy version, it's part of the basic, that it is something that's available, and it is by race and ethnicity. So that was helpful. We do participate in our SMM reports. And some of the challenge that we had about getting the patient's voice, there's some, and we had representation from our NRC reports, which are our patient, like the Prescanis, the new Prescani thing, of getting the patient's voice there. It is not easily able to get it through by race and ethnicity, because we really just get to hear what our patients say about the care. But if you do a deep dive, you're able to figure it out, but it's not readily. So I'm hoping that we can work through that. We do have a patient family perinatal group, but since COVID, it sort of died down, and there's still talk, how do we reinvigorate that, and making sure that we get the people, all people represented in that. The other thing with being part of the larger organization, the Epic is great for at that time or quick reports, but we wanted to see of things over time, like quarterly. And we do have analysts that help us with the Joint Commission, as well as some of these that are helping. Still in progress, but we're doing a whole lot better with capturing that data. Next slide. Our other goal, I told you, was about having training, and Karen just got the data from our friends from PQI that we have over 50 nurses and providers from the Brigham who have participated in this training. And now happy to hear that we've got one more. We'll do the push out to get people get people to join up to March so we can boost that number. Every person that I've talked to who has attended have found that it's particularly helpful, and even more helpful than the ones that we have done overall, because it really speaks to our population. The other goal that we had was for our language interpretation. And we have switched to this new company, that AMN, the iPads being available for all patients. There was talk to put them in every room, and some was there, but there's challenges with that as well in terms of having missing cords, having it there, all that stuff. So we do have about 5 readily available on either side, on wheels, charged, hopefully, that we can have them, the video interpreters. And it's so many languages. It's been really helpful. Sometimes the challenge with the video, I find in our area more than the rest of the hospital, is that sometimes somebody's breastfeeding or somebody doesn't want to be seen. So we're videoing to the face-to-face to the ceiling, so the patient, keeping the patient's privacy intact. And then our other goal was about education and making sure it was available in language. We had to work through a few snafus in Epic with our AVSs, that even though we selected Spanish, the instructions or the warning signs would be printed in English. So that's been fixed and hopefully actually improved. Always continuously improving of having it available, and most in Spanish, but more languages are becoming more available. So again, ongoing work that we're doing. And then I want to hand it off to Karen, who's going to talk about our TeamBirth, and being part of this has been really helpful. Take it away, Karen.
All right. Hi, everybody. I'm Karen Manganaro. I'm a nurse educator at Brigham Women's Hospital and part of the PNQIN leadership team. I'm just going to talk a little bit about TeamBirth. And as Mimi mentioned, key to our success with this was multidisciplinary department support from the top. We started this work back in fall of 2022. And I think you'll see as we go through talking about our process and then our outcomes, that we've had some real success and some opportunities in reaching our equity goals. TeamBirth was highlighted as our #1 quality initiative for 2023 to ensure respectful maternity care. We received a lot of feedback from our nurses and our providers, and many who believe this was already part of their practice. And I think we will show that it was not happening consistently or reliably. Next slide. So we know what respectful maternity care should look like, right? So we know that we should see shared decision-making, autonomy, informed consent. On this slide here, you can see the campaign goals and objectives from the CDC's Hear Her campaign. And one of the main objectives is to improve communication between patients and their healthcare providers. We know that when patients don't feel empowered to speak, so if we're not presenting information in a way that they really feel like they have a choice in their care, or as Mimi talked about the interpreter iPads, before we had those, we weren't consistently throughout their care offering them an interpreter. We might do it at admission and discharge teaching, but we weren't really throughout their stay consistently having that interpreter available to them. And so then they're less likely to let us know when they have a concern or feel like they had a say in their care. Next slide. So here's some actual comments from our patients. One patient shared that one thing that should be taken into consideration is that the mother should have a say on how the birth goes, not have her stay quiet, even if she has an epidural or not. I did not feel like my voice was being heard, and I was continuously told that I was a liability to the hospital and I cannot make any decisions for my own health. That was not okay. Another patient shared, my experience was unfortunate and that my wishes as a patient were ignored by the attending physician during my delivery. And another patient stated that the only growth feedback I have is that there were opportunities for including choice in my medical care that could have been clearer that they were a choice. For example, I wanted to donate umbilical cord blood to a cord blood bank and didn't realize until a few days later that no one asked me about that, and I didn't know when I should have proactively voiced that. If it wasn't an option for me for some reason, that didn't come up either. So clearly from these comments, this demonstrates that not all of our patients felt empowered or that they were included in their healthcare decisions. Next slide. So again, many of the nurses and providers really believed that they were already practicing in a way that was consistent with TeamBirth. We had patient information boards in the room and bedside discussions with the patient during their care, but how we use the boards and when the discussions happened and who attended were not consistent. A lot of conversations between just the patient and the nurse, just the provider and the nurse, or the provider and the nurse outside the room. And we really felt like TeamBirth provided that structure and the tools to consistently involve patients in their care and focus on the 4 core behaviors. Next slide. So we have a large staff to consider when rolling out TeamBirth. We have a large faculty practice, resident group, midwifery group, 6 private practice groups, and a large nursing team of about 125 nurses. So we identified an implementation team to work on the details, to really identify what were going to be the decision points when huddles would be required, who would lead them, the timing of the huddles. And you can, this team met weekly, so starting back in the fall of 2022. And you can see from this slide that there's a good representation from our provider groups, but it was really a challenge to consistently be able to include bedside nurses at these meetings. But we did have the chair of our nursing practice council as a member, and she was able to report out to that larger practice council and then bring back the feedback from that group. There was a lot of robust conversations about what should be required huddles, especially timing of the huddles in the second stage, whether they should be hourly or, could they be every 2 hours? And then particularly for our faculty practice, who could run the huddles? Did it need to be an attending? Could it be a resident? Did it need to be a chief? Could it be an intern? So this was the group who made all of those decisions. Next slide. And so we also had clinical champions from our provider groups to communicate decisions from the implementation team, hopefully to build positive momentum. And this group was assigned the task of signing up for specific times to run simulation huddles because we had that large staff to get through that training. With the census and the staffing issues and the queuing on the floor, that fell through sometimes. So honestly, in reality, I think Barb Stabile ran about 90% of our simulation trainings on the unit. But the clinical champions were great to bring the information as things changed and updates to their practices. Next slide. And then while that unit training was happening, the implementation team worked on designing our planning board. So here's our planning board. Pretty simple in design. There was a lot of conversation about word choice on this board, the layout, placement in our rooms. The inserts are Spanish on the other side so that we can flip them over. And we're working towards providing inserts in other languages as well as for a separate insert for our families with special considerations like loss. And when I think back of when we started this, our kickoff was in April of 2023, and where we were at, really struggling to get people to consistently change their practice and do these huddles, and some disappointing numbers as we started to track, whether or not huddles were done and how many, to where we are now. It's pretty impressive. And now I'm going to pass it off to Barb so she can share some of our outcomes.
Oops. Great. Thanks, Karen. Next slide. So our demographics from these are the survey results. So part of the Ariadne Labs TeamBirth cohort, we sent surveys, or we gave surveys to all of our patients who delivered, and they filled them out before they left the hospital. This is separate from the NRC surveys, which are the surveys that patients do after they've gone home that are part of the whole hospital patient safety HCAHPS information. So these were the survey, the demographics of our respondents. As you can see, the vast majority were non-Hispanic white, followed by the Hispanic, followed by Asian, and followed by non-Hispanic Black African American. Though we did have the surveys in 5 different languages, we only had 2% returned in Spanish, and the majority in English, and none in the other languages. So that was disappointing because we had worked hard to get those other languages. Ariadne had gotten them translated for us. The process that we used for the surveys was that it was on the front of their welcome packet when they were admitted to the mother-baby unit after delivery. And it was really up to that admission nurse and then the nursing on the mother-baby unit to talk to the patient about completing the survey. It did not take long to do, but it was just another thing that the new family another thing to take up their time after they'd had their baby. And so we did not have a person go around individually to each delivery, each mom who had delivered, because we just didn't have the bandwidth to be able to do that. But all in all, we did get a good response. And the numbers, pretty much the mode of delivery and the induction were pretty consistent with what we see overall with our patients. So that was reassuring that was consistent information with our other data. Next slide. So I don't know how many of you have seen the Ariadne lab data information, but this is how it was reported to us. We did have big enough numbers that we did get the data broken out by race and ethnicity. And the bar on the left, or the lighter colored bar, is if patients did not feel that they were exposed to a TeamBirth huddle. And the darker color on the right is patients who did feel that they were exposed to a TeamBirth huddle. So this was really trying to get to how patients felt included in their care. And these two questions were, could I ask questions about my care? And then could I take part in decisions about my care, which are two different things. I think, question number two, most of us feel like we can ask questions about our care. I feel like we've come a long way with that. And you can see that those numbers are pretty consistently higher than the question number one, I could take part in decisions about my care, were lower, but they all went up if the patient felt that they were exposed to a TeamBirth huddle. And they actually, one of the things that we thought was most reassuring is that they became more congruent between the different demographic groups. So the not exposed to a huddle were a little bit more dissimilar than the ones after they felt like they were exposed to a huddle were more congruent with each other. Next slide. And then these are two more questions, again, displayed the same way, but really looking at, did my healthcare team do a good job listening to me, and I felt heard, and my choices were respected by my healthcare team. And we heard this again and again, both in these responses as well as in the comments that patients wrote on their surveys, that they felt heard, listened to, and that their choices were respected by the healthcare team. And it was definitely more so in patients who felt like they had experienced a TeamBirth huddle. The only one that was a little bit weird is in question number 4, the Hispanic patients. It went down a tad. We can't explain that, but all of the others went up consistently. And one thing that surprised us a little bit was that the Asian patients seemed to start a little bit lower and go up more, which was interesting. We hadn't really expected that. And as you can see, again, patients who felt like they'd been involved in a TeamBirth huddle had more congruent answers than before when they did not feel involved in a TeamBirth huddle. Next slide, please. These are some of the quotes from the patient comments. We were really happy that patients took the time to actually write down comments on these questionnaires. I was particularly grateful and impressed with the access to specialists to discuss the pros and cons of forceps and to have had a successful forceps delivery. We were able to get the comments with their race and ethnicity, as well as if they felt like they'd been exposed to a TeamBirth huddle. That was a non-Hispanic white patient. And then a non-Hispanic Black patient said, I believe their patient knows their body the best, which is consistent with Dr. Barfield's initial quote in the slides that Karen presented, and should trust their instincts rather than going off of popular opinion. Thanks to everyone who assisted in the successful birth of my baby. Next slide. And patients felt respected and cared for. My L&D team were amazing, kind, and supportive. They explained everything well and respected my choices. Thank you. A non-Hispanic white mom, and the doctor, midwives, and nurses were amazing and attentive. They were very patient, understanding, and communicated well with me regarding my care and my baby's care. I can't thank them enough. They checked in on us regularly and made sure we felt heard, safe, and cared for. I would definitely recommend this hospital to others. Thank you again. A non-Hispanic Black family. So those quotes really do bring home how important this is and how wonderful it is when patients do feel included in the care. that they are receiving. We shared these comments in our weekly newsletters every Friday, and we put in comments from patients that really help demonstrate the patient feeling respected, cared for, listened to, and included in her choices. Next slide. And now Emily's going to talk about the provider outcomes, because that was a part of what we looked at as a part of the TeamBirth as well. Emily?
Can you guys hear me okay? I have new headphones.
Yep.
Perfect. All right.
I can hear you.
Haley, you can go to the next slide. So we were in the unique position that, given TeamBirth was our top priority for quality improvement for 2023, we combined it with our safety program that obstetricians and midwives are required to complete. And so, one, we had full participation from all our obstetricians and midwives, which was great to get involvement from those teams. And then they were all required to complete a pre and post implementation survey. So we had great responses back from our teams, which helped us also think about how to maintain the gains as we go forward, and also to understand sort of how provider and midwives' perceptions of the quality improvement changed over time. So I'll show you the results of these, and these are from about 130 obstetrician midwives and some labor nurses as well. You can go to the next slide. So following this slide, everything on the left is pre-implementation, and then we did a follow-up survey 6 months later, which is post-implementation. So you'll see both of these as we go through. But, you know, about half of them were from OB attendings, 30% were from residents, 4% were from fellows, about 12% from midwives, and then we had a small amount of our L&D nurses also submit surveys. Next slide. So we asked providers if they thought TeamBirth was important. You know, in the beginning, about 30% agreed that it was before we took it on, and 30% strongly agreed and 50% agreed. And we were able to, you know, move that mark some. The amount that strongly disagreed significantly changed. So more people were on board, although we had a high sort of positivity and acceptance of the QI initiative before we even started. Then we asked if it was feasible. And this is where I think we found a lot of gains. I'll show some interesting feedback from the end, but I think people thought it was going to be harder than it actually was to implement, and thought it was going to take more time and resources on the provider end. And I think most of the feedback was it took less time than most people thought. Next was the question if it was a good use of QI resources, and we did have about 2/3 of providers say that they either strongly agreed or agreed with that statement. We did get some feedback that although they felt like it was a good use of QI resources, in the comments they felt like maybe the resources could be put somewhere else, but overall there was general support of implementation of the program. Providers were asked if it appropriately addressed issues on our labor floor, and this is where we thought the data was a little bit interesting. So half either strongly agreed or agreed, and it really didn't change post-implementation, and about half of respondents either said neither, so were sort of ambiguous, or disagreed with that statement, which we thought was a little bit interesting given the goals of TeamBirth, and an area to explore further. My slide paused. I can't tell if it paused for everyone else. There we go. TeamBirth improved patient experience, and I think overwhelmingly people agreed or strongly agreed, or were ambivalent about it, and very few participants disagreed with that statement. So I think when thinking about patient experience and some of the data that Barb presented, I think, you know, most people thought the experience was improved. We asked if it improved provider experience, and there was a mixed bag here. You know, I think, you know, 32 to 36% of participants neither agreed or disagreed. I think when asking physicians and midwives about it, they felt like it was already part of their practice and this formalized that process. So I think that might be where this comes from a bit, but it didn't change that significantly pre or post implementation as well. But I think it came from the place that most people felt like they already were doing this, and TeamBirth allowed a more formal process and documentation of it. And we asked if participants felt that TeamBirth decreased provider burnout, and results were all over the board here. About 15% percentage pre and about 18 post agreed or strongly agreed. About 40 to 40% said neither, and about a third of participants disagreed with that. I think, again, when asking for individual responses here, they felt like it just wasn't an intervention that addressed provider burnout. That wasn't the point of it. That wasn't one of the objectives, and implementation of it didn't really affect it as well. Asked if TeamBirth decreases disparities, and I think, a majority, over 2/3, either strongly agreed or agreed with that response. And so, as it was one of the major focuses of the implementation as well, I think most providers thought that it helped to address disparities. And then when asked just post-implementation if they thought TeamBirth huddles were burdensome, most people either didn't think they were burdensome or were ambivalent about it. So only about 19% agreed with that statement, that they felt like they were burdensome, but most people felt like they were easy to do and not a burden on the clinical care or workflow. Mine's just stalled over here. So I think from a provider perspective, the major burdens to huddles were timing, logistics, acuity constraints. And when you go through the comments, they felt like if there was an urgency on admission or logistics of assembling the entire team, particularly on our teaching service, sometimes that would be a barrier to a huddle. Patients being in triage for a long time and therefore delayed admission to the floor, and so a variable timing of the admission huddle. Just adjusting to the workflow of the huddle, but I think that was more in the beginning. By the end, I think the workflow was pretty clear. And then some people just commented that they didn't identify any barriers. That was quite easy to do. Some other comments included that getting the patient comfortable, particularly if they were admitted in active labor, it just felt like not the right time to sit and do the huddle. Language or interpreter use, although I think by the end, the use of video iPad interpreters has really changed that, and it's been a more remarkable implementation on our labor floor. And then some just very practical things, like there wasn't a pen, or the whiteboard wasn't there, but things that were identified early on. Other comments we saw pre-implementation from physicians and midwives, they said, I don't think that it changes a lot from what I was previously doing, reviewing the goals and plans with the patient, communicating with the nurse. There was lots of sentiment that this is how the providers had already been practicing, concerns about disruptions to patients or evidence behind the initiative, and didn't really address culture issues on our labor floor. So kind of to the point of, was it a good use of QI resources, and what was the opportunity cost of those resources? Those were most of the things that providers identified. Post-implementation, the comments were quite positive. Patients really liked this intervention. I think it made a huge impact on experience. It also helped involve the support people. The components were already occurring in my own practice and how I communicate with patients and nurses. It seemed formulaic, but I could appreciate why it was being done. And some differences in opinion on when the huddles were indicated, particularly antepartum patients that sometimes are on our labor floor awaiting a bed for long periods of time. And then I think the other component to it that we're trying to implement in 2024 is the post-delivery huddle. Again, trying to find an organic time to do it that feels that it's an effective time, and also a time that both the nurse and the patient support people and the physician or midwife can have the time dedicated to complete it. Other comments we saw post-implementation, a provider commented that it was most important for helping to explicitly include patients in their care, show how that their opinions and preferences mattered. It was important that it can empower them to ask questions and that all the questions were answered in a way that the patient felt comfortable. The provider said, while I share the goals of TeamBirth, I'm concerned there are other very important issues impacting our patients and providers that don't seem to be receiving the same level of attention, and that hope in the future that more resources could be allocated to this, but again, acknowledging the value and importance of TeamBirth. I think the main takeaways from the physicians and midwives that the vast majority agreed with the TeamBirth goals. They felt like it was feasible and generally a good use of QI resources. They were more likely to strongly agree that TeamBirth was an improved patient experience, and post-intervention, more people disagreed with the statement that it appropriately addressed issues on our labor force, so still trying to elucidate what providers and midwives might think should be addressed in the future. But I think it was a unique opportunity to have 100% completion from all our physicians and midwives to get a sense of their experience of TeamBirth and then use it as information for all of our QI projects, but how to sustain our gains with TeamBirth. And we talked about some of the barriers, but otherwise, I think generally there weren't a lot of barriers to implementation.
Thanks, Emily. Just some general summary and lessons learned. We have had success implementing TeamBirth at Brigham and Women's, and it has been very gratifying as well as challenging. One of the keys is leadership buy-in. So it was so important that we had our Chief of Labor and Delivery, Dr. Barbieri's buy-in, and the nursing leadership at the local level, as well as at the more senior level. Our Associate Chief Nurse was very invested in it, as well as our Chief Nursing Officer. So we did have buy-in throughout our system. Team involvement, we really like to emphasize the nothing about me without me, one of my favorite quotes in healthcare, and really trying to emphasize the fact that you need the team at the bedside, which includes the nurse, the patient's family, as well as the provider. And that was a bit of a challenge, actually, because trying to get all those people, it doesn't seem like it should be that hard, but trying to make sure that those people are present for a huddle was a little bit more challenging than we thought it would be. But providers did work on it with us and with the nursing team to make sure that when they went in the room, that the nurse was aware when the provider was in the room and could be in the room with the patient as well. Accountability, it's hard to say. We do have a SMART phrase when a TeamBirth huddle has happened that's in the chart, but we haven't been able to do any real-time exploration of when the huddles are happening and the quality of the huddles. That is something that will be coming in the future that the team has talked about. And then one of the really keys with any QI initiative, I think, is sharing and celebrating the success stories as well as the opportunities. As Emily was talking about the post-delivery huddle, we didn't think that would be as much of a challenge, but it was a challenge because the provider may want to do it before they leave the room, but then the patient's getting cleaned up, the nurse is trying to get everything organized after delivery, and that's not an opportune time for the nurse or the patient typically. So we've experimented with a couple of different ways of seeing when that could happen, as Emily said, more organically and a better time for everybody. So we'd be happy to hear your questions and answer any concerns. Thank you.
Wow, I am just blown away by you guys' presentation. That was really, really awesome. I just want to say, and I am, one of those who think that we use too many superlatives in today's language, and that is, I mean that awesome, right? Like that was really terrific. I want to say thank you to your team and thank you for all the work you've done. I think just what you've presented too truly shows, exactly what we were hoping to accomplish with pushing forward an equity bundle is, it's not that what having an equity bundle said, okay, people are like starting from go, like you presented. Brigham and Women's, Mass General Brigham was already on an equity journey.
Mhm.
And it was just about what are some of these actual tangible tools to really put things together. And so I think that, you know, your equity committee has done a really tremendous amount of work. We have learned from preliminary data from our study that leadership is number one. And I loved your take-home points that leadership buy-in was key. Without that, I mean, I think that is one major thing to say for everybody. Without that, trying to get the work moving forward. And also to your point, Mimi, when you talked about getting the data would have just likely not been feasible without that leadership buy-in. And so my question was really around that is, when you say leadership buy-in, or when you think about leadership buy-in, are you thinking one particular person or a group of people? And what are the leaders you think that others may be listening that may be having challenges with leadership buy-in? Who are some of the folks that they should be reaching out to? Is it the chair of the department, the chief nursing officer, the diversity, equity, inclusion office at their hospital system? Who are you thinking of when you say leadership?
It's Mimi. I would have to say all of the things that you had said. And it was helpful to have their buy-in because they validated that, yes, it is important. And you guys are on the right track and we need to support this work. And how can we help you? But it also brought some challenges because they all had a voice and wanted a piece of it. Right. So how do we work together? And I think, as Emily said, having it part of their safety, you know, I do feel that we all think that we're doing everything right, because we want to provide the best care for patients. But as Karen and showed that, you know, our patients don't always feel that. So seeing that data helps to have nurses realize, oh, yes, I do want to provide this care. I think I do provide this care, but getting the data and getting that feedback to say, well, maybe, and being open to that feedback, really, right? To say, maybe I have room for improvement, right? And what can we do about it? Having nursing leadership to say, yes, this is important. We'll pay nurses to get this training. We'll make the time for nurses to make this training. We'll have our practice councils. All those things were helpful. Oops, it looks like we're done, huh?
Yeah, we're just at the 2 minutes left. I also just wanted to share for those, you know, we partnered with TeamBirth in the equity bundle in order to make sure that teams who were doing the equity bundle would have access to a very specific tool to engage in the patient-centered piece of this. And I think this is a really great presentation to encourage anyone who may want to get involved with TeamBirth to think about moving that direction to support a method for collecting patient experience information, engaging your entire faculty and staff on a process around engaging patients, and then hearing their voice. Because I really love how you guys presented the quotes that you got from your patients. I thought that was terrific. And I missed the TeamBirth final presentation that happened on Friday of last week because I was teaching. And I'm sure there's some really great things that came out of that as well. It was just fantastic to partner with TeamBirth, and I think you guys just presented a really good example as to why.
If anyone has a question, we still have a minute. I just wanted us to be able to see everybody for the last couple minutes.
Lots of accolades in the chat, so congratulations, guys.
Thank you.
This
Still
is
more
great.
work to do. We're not done.
This is great. Well, want to end on time and respect everybody's time. So I just want to say thank you to you guys and thank you for everyone joining. We look forward to our presentation next month where we can continue these and more to come.
Yep, we hope you all can join us February 20th at noon to hear from Mercy Medical Center. So thank you all for joining. Thank you, Brigham team.
Thank you.
Thank
Thanks, everyone.
you.
Bye.
Stay warm.